Okay, we'll go ahead and start anyway. I think we're privileged to have Dr. Craven, who all of you know as Chief of the Glaucoma Division. He has additional qualifications and expertise in the subject of risk management, and based on that experience, and OMIC, for those of you who do not know that, what OMIC is, it's the largest ophthalmic malpractice insurance company in the United States, which insures a large number of ophthalmologists. And he has been responsible for creating documents within that system on how the best to protect both patients and also physicians from claims. Dr. Craven actually gave a portion of this talk to the glaucoma division a while ago, and I think we all felt that it was important that each one of us get an opportunity to listen to this talk, because it's an issue that is becoming more and more relevant in the kingdom and worldwide. So without much ado, thank Dr. Craven for teaching us on this subject. Thank you. Next.
All right. Well, as Deepak mentioned, the risk management area has been a love of mine for a number of years. About, 20 years ago, I was contacted by the American Academy of Ophthalmology, and they had just formed a small medical malpractice company because of a crisis that was occurring in the United States. The cost of medical malpractice insurance had skyrocketed to where it was approaching $20,000 to $30,000 per year per physician for getting medical malpractice insurance. So this was a crisis that occurred back in the kind of mid-1980s originally. So what we figured out at the American Academy of Ophthalmology is that we could actually insure ourselves, because ophthalmology claims are very unique. The standard medical malpractice claim is really so general that it allows the jury to sit there and listen to the details about the case, and they can make pretty much assumptive conclusions on it. And they found that if experts look at the results of what the jury finds for medical malpractice for just a general case, like a surgery case or internal medicine, it's usually pretty close to what they thought it should have been. Now, ophthalmology, on the other hand, because it's so specific and the details are so clouded, in a sense, to figure out, under 50% of the time that the claims kind of matched with what an expert group thought it should have been, okay? So just a history on medical malpractice globally, in the entire world, just so you guys kind of get this. I think it's very important in Saudi Arabia to understand this. Between 1792, okay, so just after the United States had been formed, and 1952, so that's like well over 100 and some odd years, there was very few claims that had occurred. A total of 24 claims, medical malpractice claims, had taken place in the United States over those periods of times, over those decades. But then in 1954 to 1975, there were tens of thousands of medical malpractice claims. Does anybody know what happened in 1954? Television. So once television came out and media came into play, the amount of malpractice claims started to go up. And if you think about it, really what happens with people getting stirred up to want to file a complaint or to want to sue somebody, it's usually related to them seeing something positive of it from either social interaction or television, where they hear about somebody winning a jury award for millions of dollars, and then they think, well, this is easy, I can get the $2 million if something happens to me. So this creates a change. Now, right now in the kingdom, we're experiencing a social media boom, okay? And social media becomes a way for people to start texting each other or basically sharing each other on Facebook or whatever about what happened. And this creates this whole stir of problems that comes out of this, okay? So what happened during the early 1990s is we tried to start getting a handle on what it is that we can do as doctors to prevent us from being open to losing a complaint or a suit, and how can we protect ourselves. and if you talk to doctors that have been through a suit or a complaint, it's extremely stressful because, I mean, as soon as you hear you've had a formal complaint filed against you or you've had a suit, you can't sleep that night. I mean, that's almost what always happens to everybody. And then you start doubting what you do, so you go to work the next day and you think, gosh, I can't have this happen again, and your whole life starts to change around this complaint or this suit. And emotionally, it's a very, very intense thing to go through. So what we're going to go through today is just kind of the facts around it, and then and Ohoud's going to talk about what the laws are in Saudi Arabia and how a complaint is handled. But then I'm going to give you some clues about ways of trying to keep yourself out of trouble. But the number one thing, the number one thread through everything here is the medical record. And the reason for that is, if you think about it, that's really all some other body or group has to look at as what's on the record. So if something's not on the record, then it wasn't done. So just remember that. So, as far as what prompts a patient to sue or to complain, the first thing is usually they get mad. And that might be because they expected, we have this all the time in the glaucoma service. When we operate on somebody, they thought we were doing it because they're going to see better. So they assume that they're supposed to see better and not we're controlling the pressure. So there's a disconnection between the patient's expectations and what we do. And that usually prompts them to get angry about it. And then that gets stirred up frequently because there's something that doesn't go the way that they wanted it to. So they had an unexpected outcome. Their expectations for the surgery wasn't the same as what you did. And as I mentioned through the social media thing and media in general, economic reasons are becoming a much bigger push for people because they see this pot of gold from some kind of a claim that can come out of a malpractice thing. And even though the events may not be that bad that happened to them, great case is in the United States, there was a airline pilot that went from 2015 to 2020, all right, with his vision after LASIK, and he won $4 million for that loss of vision. All right, it was beyond the policy limits that OMIC covered. The doctor had to come up with $2 million himself to cover that, to be able to cover the difference for that, all over his vision going from 2015 to 2020. And, these kind of things, but it was all about money. I mean, that's really what drove him to do that. The other common thing that if you talk to plaintiffs, which means people that are suing you or complaining against you, is that they usually feel that there was some deception. They feel that you didn't tell them the truth about what to expect with the surgery, or they feel that somehow there was something you were promising them or thinking should happen for them that didn't. And then you're covering up and you didn't really do enough with this, and that especially ties into, like referrals and them getting seen in a timely manner. So the things that we're going to go through today is to talk about what is informed consent and what's risk management. These are terms you need to learn. In fact, Deepak and I are on the Johns Hopkins current faculty where we have to redo these risk management programs online. And whenever you're on Johns Hopkins faculty, you have a yearly or every 2 years a management program for risk management where you have to go through an online or a live seminar about what you can do to prevent trouble. So let's just go through. Now, this is a fictitious story, all right, but there's some truths hidden within it. And for my glaucoma colleagues, I apologize if any of you feel this is, pointing at you, but it's just in general about things that happen. And this is all these elements in here are true. They actually did happen, but it's kind of mixed in with one tale. So this patient presented to the emergency room, had a high IOP, was seen by one of the glaucoma fellows who changed the medicines and said, you need a tube surgery. So the patient heads out, comes back into the clinic, sees another fellow and a different attending who says, yeah, you need surgery. And then they talk about scheduling the surgery. Well, the patient comes back through a series of missed things that happen with it getting scheduled in the OR, sees another fellow who schedules a case with yet a different attending. So then the patient misses the surgery, it's put onto the waiting list, and it shows up on another attending surgery list, all right? And you go to the informed consent, and when you look at it, what it says is per Dr. Blank as far as what the risks and the benefits of this are. And this is what the fellows have been told to write into the medical record, is that you just write per doctor whatever. Even though per doctor hadn't even seen this patient, that might be a problem, okay? So the theme of all of this is that there was a patient who has the standard kind of things that can happen, which is where they're seen by one doctor, one attending, go to another one, which we try to avoid, but it can happen, and then goes to the waiting list and comes in yet to see somebody else. And this is a potential for risks, and this is where informed consent is even more important. So in the operating room, it's discovered that a CPC wasn't the best option for this patient, so they do a trabeculectomy. The next day, there was a massive suprachoroidal hemorrhage, and the eye is no light perception. So this presents a series of problems from many aspects. One is management of the patient, because we should try to do it efficiently and quickly and straightforward and not bounce them around. But then also continuity of care and consistency. So the patient had different perceptions about what they were expecting for the surgeries because there had been many things told to the patient. So then the patient says, okay, I want to complain to someone because now I've lost my vision in this eye. I'm not happy about this. Who's likely to get blamed for this, and who's really at fault for what happened? Because the patient's going to want to blame somebody. And this is where risk management comes in and trying to figure out how to protect yourself or insulate yourself from complaints. So what happens with a case? Well, in the US and the UK, there's what we call the tort system. And the tort system basically is where you get served a paper that says, you're being summoned for a suit because you did this. But the key 4 elements are very similar to what we have in the kingdom here. One is that you had duty. That means you had an obligation or responsibility to take care of the patient. So in other words, it's your patient, all right? 2, a negligent act occurred. That means that something happened that they can pin on you. So the trabeculectomy was done, then a subsequent hemorrhage happened. The negligent act was how you did the trabeculectomy, okay? The 3rd is causation. So in other words, the hemorrhage happened because of the trabeculectomy. And then damages. The patient can't see, so there's damages that have been found. And in the kingdom, we have a similar type of thing tied into complaint systems. But these 4 elements are always important to remember whenever you're doing informed consents, because if you think about it in terms of the fact that you already know you're their doctor, but you should discuss with them, what kind of things can happen with this, so you show in advance that you're thinking about it and that you're trying to prevent it. So now we're going to have Dr. Owaydha talk about what's unique about Saudi Arabia with the medical malpractice and complaint system. Then I'll finish up with discussions on informed consent and also risk management. Ohoud?
Thank you very much, Dr. Randy. Good afternoon, ladies and gentlemen, and thank you for joining us this afternoon. I'm here today because I had the opportunity to be part of, the former chair of the Irregularities and Medical Complaints Committee in Jeddah Eye Hospital. That was maybe 5 years ago. The part which I'm going to present in a few minutes is having a lot of solid information, so please, I just need your patience here. Due to increasing population and increased awareness of the health matters, the number of complaints and claims against healthcare providers and physicians has resulted in upward trend of medical malpractice litigation. And I think you can see clearly that in this chart that the number of claims increased within almost 9 or 10 years from the year 1520 to the year 1420 to the year 1429. The number of claims has almost increased by triple. The number of malpractice suits against eye care professionals is on the rise also in the wake of increasing awareness among the public. This pie chart, sorry. Yeah, I just need the laser here. It's not working. No, I need the laser. Okay. Yeah, that's better. Thank you. So you can see the light blue color here, which reflects the special surgeries among the ophthalmology is part of them. It constitutes almost 10% of the total complaint, and this is actually a very significant number. And to understand the implications of a wrongful act, it is very necessary to be fully informed about the working of the legal system here in Saudi Arabia, the acts that are likely to be considered unlawful, specific unlawful acts in medical practice, and the methods to safeguard against these. However, it's not always the law that guides us in our acts, but also the moral principles and ethical codes. The ethical principles, when duly followed, enable a medical practitioner to overcome the paternalistic approach to a patient and safeguard him or her against a wrongful act. As we all know that the Saudi Arabia's legal system is based on the principle of Islamic law, which we call it Sharia. And this Islamic law is, in general, is applied in more strict and conservative way other than the other Middle East countries or other than the other Islamic countries. The higher court decisions in Saudi Arabia and other Middle Eastern countries are persuasive but not binding, in contrast to other countries like England, for example. The law of practicing healthcare professionals first was issued on 6th of December 2005, and it sets the standards to be observed by any person licensed to practice within the healthcare profession in the Kingdom of Saudi Arabia. Actually, that law was, or made it very compulsory to each physician or each dentist, whether in the private or public sector, to have a medical insurance. Then a specialist form called the Insurance Committee was established in 2007 for the resolution of any insurance disputes on coverage matters. Now, recently, the Saudi Commission of Health Specialties made a link between giving the license of a physician or renewing his license. They linked that with the medical malpractice insurance. And actually, that link reinforced the compliance. Based on the law of practicing healthcare professionals, a specialist panel called the Sharia Medical Panel, which based on the Islamic laws, as we mentioned, was established to consider claims in respect of the medical malpractice. The cases in Saudi Arabia are ordinarily heard before a judge, and there is no jury trials here in Saudi Arabia like in the States, for example. But the Sharia Medical Panel is made up of legal and medical experts. So what are the jurisdiction of the Sharia Medical Panel? How they work? This panel considered claims of the medical malpractice in cases brought before it regarding private rights, like the compensation or the indemnity, and I'm going to talk about this in a minute. This panel also considered cases of medical malpractice which is leading to death or damage of an organ or loss of total or partial use, even in the absence of a claim for a private right. Usually, the proceedings in respect of medical malpractice, therefore, commence before the Sharia Medical Panel with the right to appeal to the Board of Grievance. So at this stage, the defendant still have the authority or the ability to appeal to the Board of Grievances, which we call it Diwanul Madhalim. And whilst an investigation is ongoing, the expatriate or the non-Saudi doctors who are the subject of an investigation might be banned from leaving the country. So to understand the process of litigation, we have three main committees here for this. We have the Primary Investigation Committee, the Medical Violation Committee, or the MVC, and the Medical Jurisprudence Committee, MJC. The Medical, or the Primary Investigation Committee, the first one, includes 3 members, a physician, a legal expert, and another physician in the specialty in which the error occurred. This primary committee will interview both the plaintiff, which is usually the patient or one of his relatives, and the defendant, which is the doctor or the physician. And they will study the medical records to find if there is an error or not. Now, if there is a clear error, then this committee will send a report to the authorized person, which is usually back to the Ministry of Health or the health issues in the MOH or the administration in a certain hospital. So, I mean, the report will be sent back to the authorized person who's responsible about the case, or to the area which initiated the case. Now, if there is no error, then this committee will try to convince the plaintiff, which is the patient. If he's not convinced, then they will send this case to the higher committee, which is the Medical Violation Committee, or the MCV. This committee has 3 physicians and legal experts, so 4 people. They will investigate any malpractice suits and violations of the regulations. They will again verify the medical errors and send the documents to the highest committee, which is the MJC, if any errors are found. And the decisions of this committee requires always the approval of the minister. The highest committee, which is the Medical Jurisprudence Committee, MJC, is headed by a judge and includes 3 physicians, 1 from the medical school, 2 from the Ministry of Health, and a legal expert, so a total of 5 people. This committee can consult again any expert in the field of specialty, so they can have their own investigation again. And they will look into all cases in which there is a claim for compensation. And here, according to the Islamic law, the compensation comes into 2 forms. Either what we call it the blood money, or in Arabic it's ad-diya, or the indemnity, again in Arabic it's called arsh. So in general, the blood money or diya is paid when there is a loss of life or death, whereas the indemnity is usually paid, or it's a compensation if there is a loss of an organ. So for example, if the patient lost 1 eye, then the doctor or the defendant should pay 50,000 riyals, for example. The tendency with damages awards has been for the courts not to award significant awards over and above the statutory diya and indemnity level. So what I mean by that is there is a maximum level of diya. So the diya is the remedy which is prescribed for wrongful death, should not exceed 300,000 riyals for a wrongful death, which is almost equal to $80,000. And the arsh compensation is prescribed for loss of an organ or bodily injury, as I mentioned before. Any healthcare professional who commits malpractice causing harm to a patient shall be liable for indemnification. And all these malpractice or all these issues shall be deemed as malpractice. I'm going to go through all this because this is really very important and we need to know it all. If there is an error in treatment or inadequate follow-up, this is malpractice. Lack of knowledge and skills that can be expected in others in the same profession, performing experimental and unprecedented surgery on a person in violation of relevant rules, conducting experiments or scientifically unestablished research on patients, administering medications to patients on experimental basis, using medical instruments or equipment without adequate knowledge of their use, or failing to take appropriate precautions to prevent damage arising from such use, failure to provide adequate monitoring or supervision, failure to consult anyone, the consultation of whom is necessitated by the condition of a patient, any provision limiting the liability of a healthcare professional or holding him accountable shall be deemed invalid. So when can we say that there is a criminal liability? The law here also sets out the fines and punishment in respect of criminal liability. So a healthcare can be captured and can be subject to imprisonment, which is not exceeding 6 months. And also he can have a fine not exceeding 100,000 riyals for breaching of the following: practicing healthcare without a license, providing false information or useful unlawful means resulting in obtaining a license to practice healthcare, and justifiably declining to treat a patient. The disciplinary liability is something which is a little bit less than the criminal. So any healthcare professional who defaults in performing any duty provided for in the law of practicing healthcare professions, or violates any codes of practice or acts contrary to professional conducts or ethics shall be subject to disciplinary actions, which can include a warning letter or a fine not exceeding 10,000 riyals and revocation of the license. And this is very important. Okay. Thank you very much.
Thank you, Ohoud. I wanted to just hit on a couple things here. You know, I think if you think about the overall package of what we provide patients, it is making sure that we diagnose them correctly, treat them appropriately, and follow them up. And those basics need to be underscored in everything that we do, because for those of you that have seen my medical record notes, you know how obsessed I am with making sure I have adequate medical records and complete notes to be able to determine what needs to be done for somebody, whether I see them or somebody else. So, you know, things that we have issues with in our life right here at KKESH that you need to be aware of and careful with, I think, are the following things. You know, I think that, you know, clearly, you know, we all are very good about what we do with treatment and adequate follow-up. We do the best we can, especially with crowded schedules, but I think we're good here. Knowledge is exceedingly good here at KKESH. The area of experimental things and conducting things, that's where we have the IRB. This is why it's really important, whenever you decide that you want to try a new thing, that you have steps to go through that to do it. I just can't emphasize that enough. You know, because it may sound like it's a good idea, and maybe you read about it in a journal or you've seen it on YouTube. You have to be cautious about implementing that for a patient if something happens to them, okay? So that's why we have steps in place for credentialing, and that's why all the changes have happened in the last 2 years. Now we're overly credentialed, it feels like sometimes. You all know what I'm talking about. But that's to protect you, okay? There's a reason for that being there. And then the other thing is that the failure to monitor and provide supervision. This ties into why we, as attendings, get notes about you're supposed to be staffing the fellows and the residents, okay? You know, because this is to protect you. It's not just because the administration is saying this, trying to make our lives difficult. There's a reason behind it, you know, and it's important to protect you, and that's why these things are there. So I just think you have to remember that. And then consultations are very important, and not to, you know, hang on to something too long, and we're all very good about doing that. And the next point I want to make is unjustifiably declining to treat a patient. This is potentially a criminal liability. So the term refusing to see a patient should leave our vocabulary here at KKESH, okay? That can't happen anymore, okay? I mean, I think you need to understand that there's no such thing as refusing. It's you're here as a healthcare provider. You're supposed to do that, and it's potentially a criminal liability to refuse, okay? So I think that word, we just need to expunge it from our vocabulary and move on. So that's my opinion on that. As you can tell, it's strong. All right, anyway, how to keep us out of getting into trouble with suits and complaints. If you look at the statistics behind medical malpractice claims. Now, when I was on the Ophthalmic Mutual Insurance Company's board of directors, I reviewed countless lawsuits, probably close to 4,000 claims in the years I was on the OMIC board. And I can tell you that in almost every case, you could figure out very quickly what happened, and almost always it ties down to a breakdown in communication. And that's because you either weren't there to see the patient and talk to him, or you were a little bit of a jerk and maybe you didn't answer their questions, you know, or you were just too busy and things happen, you know. So you have to look at these things and realize that ties into what happens to you and what the patient's perceptions are. Some of the time, it's the patients don't really understand it, so that's what prompts the suit. The feeling of desertion is extremely strong in patients' minds when they look at something. So for instance, if they have a surgery and they go into the hospital and they're left there on the floor, and you don't go see them the next day and they've had a problem, they feel deserted, okay? I can't say enough how important it is. If you have somebody who has a little bit of bleeding, or the retina's not on, or the pressure's still high, or the DSEC graph isn't attached, go in and visit them. Just for a minute, just to say hi. That human aspect of that is so important. It makes them feel that they're valued and that you care about them, okay? So really, risk management is steps that go into our daily lives and what we do for our care and trying to prevent getting a claim or a suit. It's a continuum. It starts from the minute you see the patient. It's not just a piece of paper for the informed consent. It's what happens every day in our lives of caring for patients. And involves looking at the entire process of what we do. And despite all of our aversions to track care, it might actually be good for some of these areas because it can potentially enhance communication, improve quality of documentation, and protect us in many ways. Now, on the other hand, it can cause problems because if you're busy and you don't have time to look at the patient and your back's to them and you're typing on the keyboard, all those things have to be balanced. And you have to look at that. At some point, just in the middle of your week sometime, just take a minute and think, what would this look like if I were standing in the room watching what's happening here, my behavior and what's going on, and would the patient think this is crazy or they think this is great? You have to kind of think about that sometimes because that's what they look at. So the things that are tied into claims or suits, as Ohoud brought out, it's usually issues, and these are very common in ophthalmology, related to delaying in a procedure. So like you didn't attach the retina soon enough, the cataract surgery was delayed in being done, and then the lens dislocated. The glaucoma surgery wasn't done soon enough, so the vision progressed. The eye should have been removed earlier. The nucleation should have been done long ago because the patients had persistent pain, all those things. So, but failure to treat somebody, if you see a disease that's treatable and you don't, that's a potential problem. The procedure wasn't indicated. That means that you didn't choose, or the patient thinks you didn't choose the right procedure. So in other words, in place of doing, a extracapsular surgery, you should have done a phaco. So they can get into those kind of details, and frequently what will happen, they'll talk to a family member who knows an ophthalmologist, and they'll say, well, why didn't he do this? That's usually where this comes from, okay? And then this causes problems with the whole thing. So if you understand these things and you look at it, what the elements are that are common throughout all claims and your protection is the medical record. And it is absolutely key. So, good documentation is central to everything. And, questions come up, can you change a record? So, you get a claim and it comes to you, or, you've had a complaint. Never change the record. That's all I got to tell you. Don't just leave it what it is. You didn't do the good job the first time. Don't go in and change it. That's the worst thing you can do. That's like an admission of guilt instantly, and you'll always lose. So don't do that. The other question that comes up is, say the patient calls you, and they say something to you, and you remember that phone call. Okay, and then later something happens, but they look at the record and there's no documentation of it. If you feel that this is a heated issue for the patient, so they're calling you and they're complaining. They're saying, I'm really upset because my daughter had, congenital glaucoma, and I thought that her pressure should have been down by now, and you didn't get it down. It'd probably be a good idea to just write a little note next time you get to the track care about what you recall from that discussion, if it was a heated one. I mean, it's just something about the medicine clarifications. That's not so essential. In the United States it might be, but I don't think it is here. So things that we know for ophthalmology. The big areas are cataract surgery for complaints, and I think Ohoud would probably say it's the same thing from the Sharia Council, I would guess. Refractive is certainly a big chunk of things too. Less commonly is retinal and plastics and glaucoma. So the major area is that of cataracts, and it usually relates to something that happens to the lens. The lens explodes and there's fragments in the eye, and then there needs to be a vitrectomy, and then they might get endophthalmitis. Those are the ones that tend to want to sue. And endophthalmitis is a common thing that we see, and that's the most expensive suit in the United States. If we have somebody who ends up with endophthalmitis after cataract surgery, you can almost say $250,000 minimum. because if somebody loses an eye, that's the value that it is roughly in the United States. But other things that happen with the cataracts is certainly retinal detachment, corneal damage. The other huge thing in the United States is IOL powers. Okay, so if you end up putting in the wrong IOL power, the juries have very little understanding of that. And you could see that evolving here where it's going to be expectations, because people who get LASIK procedures done or ICLs, they're usually right on, spot on, when they get that. And if you put an IOL in and it doesn't end up being spot on, they have trouble understanding that. So if you have somebody that has a funny cornea, they have a keratoconus, or you find that there's something different. The A scans are different between the two eyes. And we now have standards for what we're supposed to be looking at for our axial length measurements and IOL determinations. But it's at least worthwhile to document on the informed consent. Axial lengths were markedly different, or AC depths were different, or corneal topography was different, Ks are whatever. Or write in your progress notes somewhere, but just something that you've at least made some kind of an attempt to say that I can't predict that this IOL is going to be perfect, okay? And then at least you have some protection for yourself when that happens, okay? If it's somebody with a redetachment, just making a comment in the note that this retina, I feel, may not stay attached because it's already come off twice before, that's worthwhile doing just to protect yourself. And other things that happens with the retinal vitreous claims, it's almost always related to vitrectomies when we saw claims with OMIC. And it's usually related to something that happens with the vitrectomy and a result that occurs with that. So informed consent process, I wanted to just spend a minute on this because we now have track care that has an area where we have an informed consent region to put your consent down. And the informed consent, and I wrote here, it's what prompts a lawsuit. That really means is that it's the consent process itself that can lead to the process of somebody suing. In other words, they don't feel that they were told what they should have been told about the surgery, okay? And the legal theory of informed consent is important to know. And this was looked at in a jury that was reviewed in a jury trial in Michigan, which I'll talk about in just a minute. But there's issues that tie into us taking care of the patient with our residents and fellows and other people that also is an issue. So just my suggestion, and I'll go into that in a minute, is that you need to be open with the patients about potential complications. Something that you see that might happen. If somebody has exfoliation syndrome, you might want to write potential of zonular dehiscence and lens being lost. Or, I may need to suture this or whatever, just that you write those things down. And then what you say to the patient is you ask them, what are you expecting? And I've been doing this much more now with my glaucoma patients here, and almost every time they say, I want to see better. And then I'm going, okay, I'm back to ground zero. I got to start all over, because that's obviously they don't have realistic expectations, Plastic surgery is an area where we all have a lot of trouble with this in the United States. It's because they want to look like that 25-year-old down the street. And some of these people come in and they think you can fix them and make them look the way that they used to look. That's what they expect. So you've got to find out what their expectations are by asking them, and then have a longer discussion with them if they're not really connecting with what you're talking about, and be empathetic with them, and make sure that when you get to the point of, writing down the informed consent, you understand what the elements are. So this Illinois, I said Michigan, this Illinois jury, they went through and reviewed a bunch of juries about what they think is informed consent. And I think this is standard globally. And it's basically that whatever you tell the patient, anybody else should be able to understand, okay? You don't speak at a level that's way above them. You don't say to them medical terms. It's more like, I'm doing a surgery for glaucoma to lower your pressure, and if it doesn't keep your pressure down, I'm going to have to do the surgery again. Okay, something simple like that they can understand in those terms. And sure, you've got to use the words, and they're on the informed consent, but it's important to do that with them. Informed consent is not a release of your potential responsibility for what you're doing for the patient. That's not at all what it is. What informed consent process is something to protect you. It's really important. Okay, if you have a good note that's written in your informed consent and it goes to the complaint committee, I could almost bet you it's going to be dropped. okay? And that's because if they see that you were thinking ahead and you knew this was a problem, that means it wasn't something you did, it's something you were expecting, okay? So I am not sure I can reattach this retina. You write that right in your little comments in the informed consent. Or I'm not sure that this one surgery is going to do it. You may need 3 surgeries. Write that in the informed consent. Those are the kind of things you need to do. And again, this all begins from the first visit, and it's how the staff and everybody in the entire clinic treats people and documenting things that happen with the patients. So here's a sample statement that I would recommend you consider in your informed consent box. Rather than writing per doctor whatever or leaving it blank, just write, I discussed the surgery and options with the patient and potential expectations or events that might occur, and the patient seems to have a good understanding of that. Now, I didn't use exactly what's written down here, but I'm just using different words. But it's all along the lines of the concept of telling the people that read your records later that you actually took the time to tell this individual what was going to happen to him and what they might expect and what you were expecting, okay, whether it's good or bad. And you could write, I think there's a 99% chance of success. You could write that. I wouldn't recommend it, okay, but it's probably better to write, there's a 1% chance of risks, something like that. So just showing that you're thinking in terms of what could happen that the patient might be surprised about. So, the patient will sign the document, and we have a system for that. Are we doing it in all the clinics now, Deepak, or just all of them are doing it? And it's getting scanned into the record. So use that comment box to make sure you put things in there. And it's really important to try to not do this on the actual day of surgery. It's always good to do something in advance so patients can think about it and they can change their mind or ask you questions. It gives them a little time. Now, sometimes it's emergency, you don't have any choice, okay? We all get that. But if you have time with it and it's elective, give them a little time to do it. It's a good idea if you can have somebody else witness them signing it. At the front desk, they probably are, and I don't know if we're keeping track of that, but that's a good idea. And some people recommend the doctors sign it themselves, but obviously if we're putting in a track here, that's okay. Now, elective procedures, for instance, an ICL. I think it's really good to do more of everything. More time with the patient, more informed consent, just things that you could expect that could be different, that could occur with them, just to protect yourself. If somebody has a problem, I cannot emphasize this enough, because in all the suits that we seem to lose in the United States, the most common thread was that you didn't go in to see the patient enough or didn't spend enough time with them. So if somebody has a hemorrhage or somebody has a problem, go to the floor, keep them in the hospital a few days, but you go in personally as the attending, okay? It's not the fellow, not the resident, you need to. And because it's going to be you that's on the line at the end, and this is just a 5-minute or 2-minute talk. It's just that compassionate side. You can look at the resident or fellow's note, and the fellows should spend more time with this too, especially if they've done the surgery. And the patient will probably know you did the surgery, and then you want to spend more time with that if somebody has a problem, just so they don't get mad at you. So these are the kind of common sense things that I think we need to do. So summarizing, this is all about teamwork. And it's about consistency with doing things. Ohoud has a list of references here that I think are excellent. And this is a group here in the kingdom that's a legal group that has an overview on the malpractice here. And there's a list of those, as you can see with that. But now I'd like to spend, because we've got 5 minutes left, I tried to leave for questions and just comments, because I know this tends to stir up people emotionally. So how many of you have ever had a complaint? Well, no, I'm not going to ask you that. I've had one. In the United States. The standards are in the United States, if you're in practice 10 years, you'll have 1 suit. And that's just kind of what happens. So that means if you have an average career, you'll have 3 or 4 suits in your career, and that's just because of how the United States is. And hopefully you'll never have one here, but questions? Yes? Yeah, templates are a big problem. And in Kaiser Health System, they ended up settling a huge suit that was done collectively by a group of plaintiffs, what they call a class action suit, because they were using templates. Okay, because They just all use the same op note no matter what happened, okay? And then these doctors said, well, these attorneys said, well, we know there's a lot of bad stuff going on. And you hit it by just using these standard op notes. So my personal feeling is that if you have something happen that's unusual, write it down, modify the note at least, or just do a whole brand new one or dictate it. You know, we can still dictate. You can do that here. You know, so, and especially if it's something bad, you know, like you drop the lens in the vitreous, make sure you write that note out, you know, or the retina's not on at the end of the surgery, or the pressure's still high, or whatever your area is that you're having trouble with, you know, and think ahead. If this is, let's just say you have somebody who has endothelial dystrophy and you've done a cataract on them, and you're expecting they're going to end up needing a transplant later. That might be a note that you just kind of make sure that you have every detail on there and it's right, because later they might have trouble with the cornea, and you know, you want to just protect yourself for the future. Just think about things that could happen and try to protect yourself with it. So I think you're right, Hala. I think we have to be very careful. So the question is what do I think about templates? I think in general they're okay, but you have to be very careful and make sure each one is tailored to the patient and it has things that could keep you out of trouble. There were other questions, yes.
Thank you, Dr. Randy. Thank you, Dr. Ohoud, for a nice presentation. My question, do you think that we need to customize the consent form? For example, a consent form for patients going for refractive surgery. So we list the possible complications, and the patient has to read them one by one and to sign on them.
That's what we have. That's what I developed in the United States with OMIC, and we have those all online at omic.com, and you can see all the ones I wrote for glaucoma and cataracts and everything. And they've been reviewed by attorneys and all of that. Now, that's the custom in the United States. Okay, Canada is not quite as extreme as that, and other countries are much less extreme than that. It all depends upon your risk to benefit ratio. And some people are very obsessive and they like to give people all those details. And I think for some, if you know there's a procedure you're doing that's a high risk, you know, the more you can give, the less likelihood you have of ever losing that complaint. You know, so I mean, can you imagine if a complaint goes to the council and they look at it and they see that you gave this patient all these lists of things, they're going to say, you know, this isn't realistic. You know, so sure, that would be great, but you know, this is all about time and energy. You know, and so that's why I think just that starting off with our comment box on TrackCare is a good first step. You know, and then we go from there to, you know, to other things. And certainly we could import, I would think, templates. We could put templates in, and you could probably even use the F8 button and put the template right into the box. I would bet we could do that, you know, if we wanted to. And that's extreme kind of things. Other questions, yeah. Right, so you're... yeah, and it's all about language and communication. And so I think that's where, again, just that general comment about you had a discussion, which means in Arabic with the patient or through a translator, you know, and I used to write with so-and-so as the translator. I quit doing that now, but, you know, it may be a good idea to do that, quite honestly, you know, just because that's who really told them the informed consent for us that speak English only. You know, but I think that it's all relates to that communication and giving them enough information and them feeling okay with what you've said to them, that they can trust you and not be mad at you. That's what it boils down to. Another question, yeah. Hassan?
Thank you for this nice talk, which is important for us as practitioners working. I have questions, comment regarding to refusal to see patients. The other thing that when somebody complains against doctors, there is nothing will be against this complainers if the complaint by the end ended in the favor or the rights of the doctors, because the system will not give any compensation for the doctor who sit for 6 months or 1 year with the judge and nothing happened to this complaints, you know. The other thing, the communication, skill of communication with the patients and the family, I think it's important to be, that to be more and more addressed in any hospital care providers, because this is most of the complaint coming from the side. Doctor is not sitting, he was busy, he cannot. Regarding to refusal, some patients that might be doesn't like ex-doctors and then come to some doctors who is already, his schedule is full, cannot see this, so shouldn't be used against him. And what is the right of patient if he would like to select doctors? Is that he's having the right or not?
I'm going to let Ohoud comment on these things because she's really, especially like the news media comment and everything. So, Ohoud.
Thank you, Dr. Dibi. I think the laws are different here in Saudi Arabia rather than outside like states and the United Kingdom. But I don't understand that a physician would refuse seeing a patient unless he has very strong and logic justification for that. For example, if he cannot deal with the situation, it's beyond his capacity, or for example, if there is like something wrong with that patient in particular. Yeah, this can be done through the like internal arrangement in the members in the same department, but what we had before that this can happen if the initial physician gave an approval for that. He's okay. He's okay to send that patient to another physician. I don't know how is it going right now, but
Well, I think that again, it's all about responsibility. Okay, you know, I mean, you know, and it all relates to, you know, I know what you're saying. I understand your point, but the thing is it's still your obligation to help the patient get cared for. Okay, it's not to refuse them; it's to find the right avenue. Okay, as opposed to looking at it as a refusal, it's like, well, in place of me, let's do this. You know, it's not you saying no; it's this instead of no. Do you see what I mean? I think that's the difference, and that's really what we have to kind of get in our heads, that it's making sure people don't fall through the cracks and they get cared for. There's another couple of comments. Yeah, Hala or behind you.
yeah, this is what I mean, Dr. Hala. There is a policy for that. If the patient needs a specific doctor, then I don't think that can go easily unless the primary physician get an approval for that. Yeah.
Change the wording to, I'm going to find another solution for the patient, you know? I mean, in other words, it's still you're going to help and you're going to find the patient solution for that. But it's not like you just say, I'm just refusing. That's just the wrong.
Yeah.
Wrong
And
mentality.
as long as the patient reaches to my clinic, then I cannot say, no, I cannot see him. I should. Yes? The patient is in my clinic.
Well,
Yeah, but at
it's
the end,
not,
he's
you
a
know,
patient. I'm a physician, and I have to do it.
Hassan, I see what you're saying, and I get it, but I think that in the scope of the context of things, these are all things we can work out, we can figure it out. So I wouldn't nitpick it too much, and I see what you're saying, but for the general part of the bulk of our patients, you know, we can find solutions for them to get cared for. Another topic. Go
Dr.
ahead.
Randy, in the States, during the taking the informed consent, do you tell the patient that you will be done by a trainee?
So it's be done by what?
Done by what, sorry?
While you are taking the consent form of patient, do you tell the patient that your surgery will be done by a trainee?
Oh. I always tell the patients if they ask that I may do it or my eyes will be there making sure that it's done correctly. That's how I tell them, you know. And they understand that that means there's training, but I'm still there overseeing it. So I'm still the captain of the ship, but somebody else is driving the ship, you know, in a sense. I think that's key. Kayla? I can't speak for Saudi Arabia, but I can tell you in the United States, okay, that the individuals who write the notes are always number one responsible, okay, whatever level they are. So if it's a nurse, you know, a doctor, a trainee, they're all responsible for what they write. Now, if I'm in charge of the ship, like I said, the captain of the ship, and I'm in charge of this patient's care, I have to make sure I have good people on board with that. So ultimately, I could be drug into it, okay, and I think it'd be the same here. It's kind of common sense, but this is where you have to trust your fellows and oversee them for training and make sure that that's where it should be. Yeah, and I've seen that happen in the United States. I mean, I know of cases where they've lost because of that. Yeah.
Yeah, but Dr. Rahel, I believe as long as the fellow is part of the treating team, then he can write his note and that will be taken officially. Yeah, he's part of the team. He's part of the treating team.
Yeah, thank you, Dr. For the first, to start with the consent, I think that the very short consent what we have here is not a legal consent. We have before some from the university, they gave us a course during the residency, and it was a nice course, and the consent paper ranging from 2 to 5 papers, A4 papers. And this is really the correct consent that can protect you in front of the court.
And I think with track care, again, we can get these to be templates that are built in where a department would agree that for a PRK, this is what the consent's going to look like, okay? And then you would have that, and then that's the department, informed consent for that procedure. So I think this is coming. We're not there yet, but in the meantime, all we're asking is in the comment box to put something. I just think it shows that you're thinking about the patient.
Second comment about the refusing to see patients. There is a booklet from the Saudi Commission or from the court, or I forget from where, but it's mentioned that for the emergency cases you cannot refuse. For elective cases you can refuse treating some patient that you think some problem might happen between you and the patients.
Yeah, if it is life-threatening or vision-threatening, then nobody can say no. Now, in elective cases, it is a little bit different. So it depends, as I said, if the management is beyond the capability of that physician, then he can consult another one in the same field, and then he can proceed with either yes or no. But for the emergency, there is no way that anyone can refuse.
But it's only that if the doctor cannot treat that thing, he can refuse the elective cases, or if there is that he expects this patient is difficult, this patient might
there should be a justification for the refusal. Yes.
Yeah. The last question for Dr. Craven, for the endophthalmitis cases, what I understand from what you mentioned, that it's always the fault of the doctor?
Post-operative. And this was a huge area that fuels into drug industry and all kinds of things because, Company A said if you use my drops, you wouldn't have had endophthalmitis. And, there's this whole furor of things going on with that. And preventative treatments for preventing ophthalmitis became the main focus of these suits. So in other words, if you would have used this drop, he wouldn't have got the endophthalmitis, okay? And that's where the mentality came from all of these that was happening. It was right during the first generation of fluoroquinolones and everything that was going on with that. You kind of may have heard about a lot of that, and I'm sure you've seen it here. And that tied into the fuel for this. So usually what would happen is the patient with endophthalmitis would see the retina specialist and say, oh, well, he didn't use the Vigamox drop, so that's why he got it. That's where it comes from. That's usually what happened with these. So just you have to be aware of that little things that are said, patients pick up on, and there's no proof that prophylactic antibiotics or any specific antibiotics, in my opinion, is strong enough to say that, this is the end-all, be-all for what has to be done. And some of us use interocular or intracameral injections, some use subconjunctival. There's a whole list of things, and you could argue all those. And I think here, the infections I've seen are bad, and some of the times you just can't, they're untoward and you can't expect them. So I just think that it might be reasonable to say, if you see somebody who's had a history of bacterial keratitis, or they're kind of, you suspect that they could get infected, maybe making a little comment about that, patient at a higher risk, and we'll try to use antibiotics. That's probably will help you for those. But if somebody gets a bad infection and loses their eye, that's something you can't prevent sometimes. It's happened to most of us. Deepak?
We all see patients who have had complications or some problems from another physician from St. Elsewhere, or even our own colleagues. And I think it's really important as physicians to be really careful of what we say to the patients and how we say it, and of course be honest. And sometimes, and the point I'm getting to is, if there's a mishap in the OR, we really don't know what happened, and things happen. And so I think we need to be careful in choosing our words and judicious, and but on the other hand, still tell the truth. So that's
right.
That's the comment I want to make.
And to try to guess that you knew what happened is always a bad idea, because sometimes it's not what happened, and we don't know. Iman?